risk. And that is not the worst of it. A biopsy can, at least, distinguish men who actually do have cancer from those who probably do not. The real problem, though, is that doctors do not have a reliable way to determine which of these very small cancers that are caught by a biopsy are potentially dangerous and which will never bother a man in his lifetime. Indeed, autopsy studies show that more than half of men in their 50s and three-quarters of men in their 80s in the U.S. had prostate cancer but died of something else. That uncertainty means doctors do not know who absolutely needs treatment to survive and who would be fine without it. Such ambiguity would not be so bad if the treatments were virtually risk-free. In that case, treating everyone might be worth the extra effort and cost to save the few who actually need it. Yet the treatments are far from risk-free. Unfortunately, the prostate is situated close to the rectum, bladder, and penis, making it difficult to remove surgically or to treat with radiation without long-lasting complications. Each type of treatment comes with its own side effects. Surgery, open radical prostatectomy, often results in urinary leakage because the removal of the prostate requires the lower portion of the bladder to be disconnected from the urinary tube running through the penis. The surgeon later reconnects the bladder and urethra, but damage to the nearby muscles that control urination may lead to incontinence. Meanwhile, the nerves and blood vessels controlling erections may be severed during surgery, causing erectile dysfunction or impotence. Although advertisements typically extol lower complication rates with robot-assisted surgery, large independent studies that rigorously compare the two approaches have not been conducted. In addition to impotence, radiation therapy of the prostate often ends up damaging the rectum and bladder because it is hard to avoid radiation scatter, which hits the front of the rectum and the base of the bladder. Moreover, rectal bleeding and fecal soiling are frequent but commonly underreported side effects of both radiation therapy, including radioactive seed implants, and surgical approaches. As an aside, side effects of the medical therapies that are used for advanced cancer that requires treatment, hormonal treatments, immune therapies, or chemotherapy, include loss of sexual drive, impotence, weight gain, bone thinning, hot flashes, and heart and liver abnormalities. Thus, when a decision is made to offer treatment, the true risks must be carefully weighed against potential benefits. The evidence against PSA screening has been growing for some time. In 2008, which was the last time the Preventive Services Task Force looked at the PSA guidelines, it recommended that physicians stop testing asymptomatic men older than the age of 75. The data showed that most men with prostate cancer at 75 were more likely to die of something else. Just 1 year later, two very large prospective studies were published that seemed to settle the question for younger men as well. Referred to as the European study and the U.S. study, respectively, the two reports took otherwise healthy men, most of whom were in their 50s and 60s, and randomly divided them into two groups. One group of men was periodically screened for prostate cancer with either the PSA test or a digital rectal exam in which a physician inserts a finger into the rectum to feel for abnormalities in the prostate, or both. If either test was abnormal, a biopsy was performed, and if the biopsy showed cancer, treatment was generally recommended. The second group of men was not offered routine testing. However, they received standard medical care as needed. For example, if they started showing symptoms of prostate cancer, such as trouble urinating, which is also a sign of benign enlargement of the prostate gland, then they were tested. At the end of the specified study periods, participants were evaluated for two important outcomes. Did the tested and treated men live any longer than those not tested? Did the tested and treated men lessen their chance of dying of prostate cancer compared with those not tested? Remarkably, in neither study did the tested and treated men live any longer, and in the European study, only those who were tested and treated had about a 20% lower likelihood of dying of prostate cancer. Such a decrease in prostate cancer mortality was not found in the U.S. study. The European study went on to calculate how many men would need to be screened and treated to prevent a single death resulting from prostate cancer. Determining this so-called number needed to screen, or NNS, ratio has become increasingly important in trying to figure out